Chandrima, who's going to be Chandrima, Dr. Chandrima, you have to be ready. You have to dwell on lasers in glaucoma. Glaucoma has been a great passion of Dr. Chandrima, as has been for all our very renowned speakers in this session. She has been the recipient of the D.P. Chandra Award 2006, B.K. Mitra Award. She's been a principal investigator of one of the largest glaucoma prevalence study, and also on anti-glaucoma drugs and multinational trials for newer surgical equipments. She has been a consistent faculty of GSI, reviewer in editorial board of IJO, President Calcutta Academy of Ophthalmology, and many, many more prestigious posts. Dr. Chandrima?
Yeah, thank you very much, Dr. Chitra. Can I share my screen?
Yes, sure.
I've shared it, but I think I need a little bit of help.
I think everybody is having some sharing problem. So the admin has to really look what's going on. Okay, now we are on. Okay.
Can you see me?
Yeah, Chandrima. The slides are on, so
okay.
You can go ahead. Yeah.
I just need to put this down then. I don't know how to put this down. So thank you, Dr. Chitra, very specially for this invite. And this is actually a very humble presentation before, so to say, my teacher, Dr. Harsh Kumar, because he's the doyen of lasers in glaucoma. And my job is also much easier because he would be taking all the questions when he's here. So anyway, I move on to it. A laser is a device that emits light through a process of optical amplification based on the stimulated emission of electromagnetic waves. So the properties are monochromatic, coherent, parallelism, and brightness. It actually works through photocoagulation, where it causes heat, which denatures the protein. Then it works through photodisruption, where actually the molecules are broken and there's an explosive disruption of tissue, which can create an incision, and photoablation, where there is vaporization of tissue. And if you look at that picture there, so the photochemical effects actually can cause incision and photosensitization. Then you have the thermal effects, which are used in the ND YAG laser that we use, which can cause coagulation and again incision. And you have the ionizing effects, which cause photodisruption. So the lasers in glaucoma are used in closed angle glaucoma. We have the laser PI, which Dr. Tanuj spoke about extensively, and we have the iridoplasty. In open angle glaucoma, you have the selective laser trabeculoplasty, and in cytophotocoagulation, you have the transscleral cytophotocoagulation and the endocytophotocoagulation. So lasers in open angle glaucoma, what do? They cause an outflow of enhancement like laser trabeculoplasty, and an inflow reduction that is like cytophotocoagulation for end stage disease. Laser in angle closure cause relief of pupillary block like laser iridotomy, modification of the iris contour, thus laser trabeculoplasty, and inflow reduction, again cytophotocoagulation. So lasers in post-operative treatment, we use them for laser suturolysis and post-trabeculectomy cases, laser sclerostomy, and laser goniopuncture for post-non-penetrating surgery. So to talk a little about the photodisruptive ND-YAG laser, which is Q-switched and mode locked, it connects the anterior to the posterior chamber to relieve the pupillary block. It is relatively non-invasive, and that's how the animation is. And this is actually directly taken from Dr. Harsh Kumar's publication in the IJO. And the PSCS indications Dr. Tanuj has elaborated, so I won't go through them again. PSC actually, also he has said, so basically I wouldn't go through that in the interest of time. And PSCG also he has gone through, and they're directly from Sir's publication in IJO. So contraindications are here: neovascular glaucoma, angle closure, which causes lens-induced narrowing of the angle, drug-induced secondary angle closure, and angle narrowing caused by choroidal swelling or choroidal effusion. So the patient preparation, we generally instill 1% pilocarpine, maybe twice or thrice, 5 minutes apart, which causes meiosis and stretches the iris, which makes it much more tougher, very tough structure on which we can fire the laser shots very easily. And of course, we use propagate as a surface anesthetic. The lens choice, I think most of us use the Abraham lens and we are comfortable with it. And the energy delivered to the cornea and retina is 4 times less than that with the Weiss lens. And about the iridotomy itself, these are the specifications, which again, I won't go through in detail in the interest of time, but there is also a combined procedure where you can use the diode and the YAG together. This is generally preferred in cases where the iris is very thick, and the argon laser shots or the diode laser shots actually attenuate the iris and make it to about 1/4 the original thickness, and then coagulate the vessels in that area, and then you can actually go into that area. That's with the YAG laser, and this is what it looks like when you actually fire the YAG laser into that crater made by the diode. That's an anterior OCT picture. So post-laser management, we give steroids 4 times for 7 days to reduce the inflammation, and of course an anti-glaucoma, something like the carbonic anhydrase, to actually prevent any IOP spike post-laser. And we generally check the patient after 7 days. We see the IOP and we do a gonioscopy to see the status of the angle after the laser PI. The complications are not too many and far actually. So laser-induced inflammation, iridectomy failure, diplopia bleeding, and lens opacities. Then you have the laser peripheral iridoplasty, which actually causes an opening of the oppositional closed angle. And the indications are attack of angle closure. In plateau iris, it is one of the commonest indications, and angle closure related to size or position of the lens. And the contraindications would be advanced corneal edema or opacification, flat AC, cynical angle closure, and complications would be iritis or corneal endothelial burn and transient rise in IOP. The laser trabeculoplasty, it is relatively effective, non-invasive procedure. The laser treatment to trabecular meshwork to increase the outflow by mechanical, cellular, and biochemical theories. So the generally used nowadays is the selective laser trabeculoplasty, which actually targets the pigmented trabecular meshwork cells without causing thermal damage to the non-pigmented cells. And that's the machine specifications which are used. And the indications are chronic open angle glaucoma, exfoliation syndrome, pigmentary glaucoma, and glaucoma in aphakia and pseudophakia. So the contraindications, once again, are closed or extremely narrow angle, corneal edema, aphakia with vitreous in anterior chamber, vascular glaucoma, and acute uveitis, primary congenital glaucoma, or angle recession. And 1 second. So the complications, again, iritis, peripheral anterior synechiae, hemorrhage, corneal complications are there. Lasers are also used in malignant glaucoma. The diode laser can be used. It restores the normal forward flow of aqua, especially when accompanied by aggressive cycloplegic, mydretics, and hyperosmotic agents. And it can, the Nd:YAG beam can also be used to, it is directed to the anterior hyaloid face between the ciliary body. And you can also do a posterior capsulotomy and release that. In aphakic ciliary block glaucoma, the Nd:YAG laser can rupture the vitreous phase and break the block. In pseudophakic ciliary block glaucoma as well, you can use the Nd:YAG laser. And cytophotocoagulation, the techniques are generally scleral, transpupillary, and endolasers. And the indication is failure of multiple filtering surgeries and where surgery is not appropriate or a painful blind eye. So we have the diode laser transscleral photocoagulation, which is performed with 810 NM diode laser, and we generally use about 1500 to 2500 milliwatt for 1.5 to 3 seconds. And then you have the endolaser cytophotocoagulation, where actually the time of exposure is based on the visual effect of the ciliary process shrinkage and whitening. So the comparisons of the two, they are comparable actually, both of them. And the complications, both of them actually have almost the same complications like hyphema, IOP, spike, cataract, need of retreatment. So then we move on to the carbon dioxide laser assisted sclerostomy, which actually did not gain much of a popularity, is almost same as trabeculectomy. So after you've made the scleral flap, you basically use the carbon dioxide laser probe there and over the trabecular meshwork to dissect until the aqueous actually percolates. And the drawbacks are it's relatively a very steep learning curve and demands careful and delicate surgery. Then we have laser suturolysis, which we regularly use post trabeculectomy, and we have reopening of failed filtration sites, which are also regularly used by us. The Q-switched laser can actually vaporize and make an opening out there where there is an obstruction in the sclerostomy, and the single burst actually can be used to do it. It's quite simple. And about the femtolaser, actually, I have a very personal experience with the femtolaser because I have been using it for over almost a year now for cataract surgery. But then I would not actually use it at this moment for glaucoma surgery, because I did try it and it was very disappointing, because the LOI, that is the liquid interface which it requires, actually does not provide for trabeculectomy at the moment, but we're looking forward to a time when they'll make modifications in the docking process and probably will be able to use it for trabeculectomy very soon. And then you have the cyclodialysis laser, and you have the laser synecholysis, which are regularly used by people who do glaucoma surgery. And the other use of lasers, goniopuncture in non-penetrating surgery, which is almost becoming obsolete nowadays, non-penetrating surgery. And the blocked inner ostium can be freed with the YAG laser. Vitriolysis is there, and modifying the bleb. So that actually completes lasers in glaucoma. And thank you very much for your attention.